Hi, my name is Neha Dhavalikar,
My name is Peter Grandell.
and we are presenting our final project for our Python class on opioid prescribing patterns across prescribing specialties based on claims data for Medicare Part D prescribers. So going into our data exploration, in terms of our data set, we merged 2020 Medicare Part D prescriber claims data with a similar 2020 data set that included opioid claims data, and we merged them both based on MPI. We then narrowed and subsetted our data set to include only the top 4 prescriber types, which were family practice, internal medicine, nurse practitioner, and physician assistant. And we did this so that we could focus our analysis on the most frequent prescribers. We then created a data frame that included all the generic opioid names to further subset our data set so that we could only focus on opioids that were being prescribed. And we merged those tables on the generic names of the medication. Our meaningful question that we came up with as after we started our data exploration was, how does opioid prescribing vary across prescriber specialties, more specifically in regards to total day supply, total drug cost, and which opioids are prescribed the most frequent. After our initial exploration, when looking at the 4 most frequently occurring prescribers in our data set, we looked specifically at the top 5 opioids that each of those prescriber types prescribed. Throughout the 4, we did see 6 that were reused and recycled throughout the 4, and they were hydrocodone acetaminophen, oxycodone, oxycodone acetaminophen, topiramate, and acetaminophen with codeine.
So we managed to include two significant visualizations in our analysis of this project. The first, we opted to do a side-by-side bar chart, and this was done to compare the opioid quantities as prescribed by each specialty. And so, of course, we included the 6 most common opioids, as well as a grouping variable on the 4 most common specialties. An important note with this visualization is that it follows an expected trend in which the most common prescribing specialty had the most prescriptions per each opioid group. A slight exception to this pattern is in topiramate prescribing, in which nurse practitioners had slightly higher rates of prescribing this medication as opposed to internal medicine and physician assistants. Okay, and in our second visualization, we took a look at 2 quantitative variables here, and this was opioid total cost versus opioid total days supply. And so we wanted to look at sort of a linear kind of relationship that would exist between these 2 variables as expected. And for the most part, it seems to follow this certain trend. It seems to be a common outlier in the red variable, which represents oxycodone and acetaminophen. And this especially applies to the family practice or the circles. As you can see, there are some significantly high opioid total supply days as they relate to opioid total drug costs. And oxycodone with acetaminophen also seem to have slightly higher total drug costs as compared to the rest of the medications. One last note is that topiramate had significantly lower opioid total drug costs and total supplies compared to the other medications. And here are our methods that we used for some of the analysis. So for our predictor and outcome variables, we set our predictors to include prescriber types and opioid total drug costs in the ultimate goal of predicting the opioid that was prescribed using the generic name. And our initial test size was set to 20%. We used a naive-Bayes supervised machine learning model to try and predict the initial generic drug prescribed. This is mildly successful with an overall accuracy score of 0.233, with similar or exact recall and precision scores as well. The other algorithm we used was the supervised machine learning algorithm of k nearest neighbors. We did 2 of these initial models. first having n neighbors set to 15, our algorithm was set to auto for speed, and we had a relatively low accuracy score, lower than naive Bayes, which resulted to be 0.165. In order to try to adjust the parameters of the k nearest neighbors, we increased the number of relative neighbors of predictive quantity to be 50. We changed the algorithm to a different one than auto, which is selected to be ball tree, and our new accuracy score resulted at 0.211.
So going into our conclusion, a brief discussion on our analysis. Our accuracy scores of 0.165 and 0.211 from the k nearest neighbors, as well as our 0.233 accuracy score from our naive Bayes, were not the strongest. So we wanted to note some areas of improvement in our prediction models. For the k nearest neighbors, we can in the future change the n neighbors value, change the algorithm, or change the weights. As for the naive Bayes, we can increase our test size, adjust by adding or deleting predictors, or changing parameters in the default state. And we can adjust those going forward and see if we can get some better prediction scores from there.
So for our overall conclusion in regards to our initial meaningful question, we first discovered that there was not much variation between the most frequent opioids prescribed. As previously noted, 5 out of 6 were the same across the 4 most frequent prescribing specialties, and also that the top specialties prescribing the most opioids may have resulted from this because they are more than likely the most accessible specialties for patients. This is due to the specialties being things like family practice, internal medicine, NPs or PAs, where patients may not need a referral, and their initial visits may be more likely to be covered by insurance, and it may be easier for patients to access care from these specialties as well. Finally, overall, we came to the conclusion that it may be difficult to predict opioids that get prescribed by specialty alone, for various reasons, but mainly due to probably some of the clinical prescribing practice overlaps between each specialties. Because in treating pain management and palliative care, there are many similar treatment algorithms that can be used in describing which opioid to use. And so for further clarification and better predictive analysis, it may be feasible to seek out more information besides prescriber type and opioid type, which may involve additional data sets, additional variables, or simply changing the parameters of your analysis. Thank you very much. We hope you enjoyed our presentation.
Thank you.